You genuinely changed my life after last time I saw you, very unexpectedly. Our original episode had so much attention.
Often women who have endometriosis, polycystic ovarian disorder, OCD, ADHD, there is a sensitivity to your changing hormone levels.
When I've spoken about it since on my Instagram, this is probably the first time I'm speaking publicly about it at all.
Hormones are the safest thing I've ever prescribed. The hormones we prescribe usually, they are biochemically exactly the same as the hormones we produce, which makes them very, very safe, really.
Dr. Louise Newson is a GP and hormone specialist and Sunday Times bestseller of the definitive guide to perimenopause and menopause.
Everybody needs these hormones to function in our body, but some people's bodies are more sensitive when hormone levels change, and that's the problem.
How are hormones also working in our brain? How is it affecting us that much in a mental health capacity?
It's just these three hormones that have been neglected really forever. They're very powerful and they have really important effects.
I'm your host, Sarah Ann Macklin, and I'm on a mission to uncover the maze of health myths around nutrition and well-being and guide you through my 7 pillars of health. Join me on a journey of discovery and connection and pull up a pew for a front row seat to the most exclusive health conversations of our time. Welcome to Live Well, Be Well. If you've watched one episode and enjoyed it, I'd love to ask in agreement for you to subscribe to the show. Subscribing is such a small thing, but gives so much exposure, bringing bigger guests, bigger production, and more that we can deliver each week to more people. Every time you subscribe, it shows me that you enjoy the content. So if you do me a favour, and if you've enjoyed the show, please press subscribe. Dr. Louise Newson, welcome back to Live Well, Be Well. I am so happy to have you here for the second time in a very short run-up because our original episode had so much attention, but was also, without saying this as I was blowing something up, you genuinely changed my life after last time I saw you, very unexpectedly. Had no intention that was going to happen, but the conversation for me changed my life. So we're going to go into that today and why it changed my life. But I want to start with a stat, which is what I always love to do. Because when I was looking more around PMS and PMDD, which is what we're going to talk about today, and we're going to divulge what those terms mean, I wanted to see how much the population suffer with it. And so maybe no surprise, 90% of women can suffer with PMS symptoms, which is huge. But then when we think about PMDD, and this might be a new term that people haven't heard about, maybe listening to this show, it says it's only 5%. And so I wanted to ask, do you think these stats could be even higher for PMDD sufferers?
I think when we look at PMS, it's premenstrual syndrome, so something that happens to us before our periods. Now, our natural hormones, so when people are having natural periods, we know that graph, some of us are taught at school, where we have a surge in our hormones when we ovulate and then it drops down, and then we have a little rise and a steady fall just before our periods. Periods is when hormone levels are at their lowest. So that happens to everybody. Some people don't notice, but I think it's quite a challenge to find a woman who's never felt anything just before their periods. And there's been a debate in literature for decades about PMS. Is it a syndrome? Is it a disorder? Is it a disease? Is it something that's natural? And there's lots of people that say nothing can be a disease if it affects everybody. But actually it doesn't matter what it's called. It's something that affects women, And then PMDD is premenstrual dysphoric disorder. Bit of a mouthful, that's why it's easy to say PMDD, but basically it just means you're having, I don't know, am I allowed to swear? You're just having more of a shit time, and the symptoms are more extreme. So you don't have to have a certain number of symptoms or a certain, lots of people talk about the diagnostic criteria, but actually women can decide themselves often. And it's when people have this extreme, either physical, psychological, but often both symptoms, usually, and I say usually because hormones can really fluctuate, but usually before their periods. Now, some books say 5%, like you say, and you think, oh, only 5%. That's still 1 in 20. So in a class of 40, that's 2 children, if it was all girls. But you know what I mean? It's still a lot of people that will have PMDD. But I think it will be a lot higher, actually. And I think there are certain groups of people where it's more common. And increasingly when I talk to women, often women who have endometriosis, women who have polycystic ovarian disorder, women who have OCD, ADHD, it's like a big Venn diagram really, but there are people that there's this overlap where they have more than one condition. And basically, I think in simple terms, it just means there is a sensitivity to your changing hormone levels, if you see what I mean. So, you can't have a blood test or a scan and go, yes, I've got PMS. Yes, I've got PMDD. Doesn't work like that. And that's where it's been hard to diagnose over the years, because people have been told, oh no, it's all in your mind. Of course you don't feel like that, because there isn't anything to see. It's not like having a rash in your face or your, some spots that come up and I can go, yeah, actually, that looks like X disorder. This is often something people feel. And then also when you have your period, often things feel better again. And okay, it wasn't that bad. And then it happens again. But for some women, it can be absolutely unbearable. And, the psychological impact can really not be underestimated. And that's the side that really scares me. But actually, the symptoms, and there's dozens of symptoms, are actually the same as the symptoms of perimenopause and menopause, because it's sensitivity to hormones. And some people's, everybody needs these hormones to function in our body, but some people's bodies, especially their brains, are more sensitive when hormone levels change. And that's the problem. And when I talk about hormones, I only mean the three sort of so-called sex hormones: estradiol, which is a good form of estrogen, progesterone and testosterone. We've got hundreds of hormones in our body that do thousands of different actions in our body, but it's just these three hormones that have been neglected really forever. But they're very powerful and they have really important effects in the body.
I think just what you said there is so much I want to pick up on, because I think when we had our original conversation, so anyone who's not listened to this, please go back and listen to it. It was about early menopause, perimenopause. And, for someone who was in her 30s, I was having this conversation, but, wasn't as connected to it as maybe this conversation.
Yes.
And as you were talking, I was going, this feels quite similar to me. Am I in a perimenopause? And I wasn't in a perimenopause, but my hormones were not, I don't want to say stable, because hormones are never stable, but they weren't probably in the best place, because I was having really bad anxiety, really heavy periods, very emotional just before my period, but the other 2 weeks I was fine. And it is really confusing. I think so many women have just accepted that this is how they're meant to feel. And I also think there's a lot of conversations where men might say, oh, you're just on your period, or, I know when you're coming up to your period, and it can trigger a woman. So it can be very hard and very stigmatizing to actually be open about how you're feeling. And I think when we had that conversation on the podcast, for myself, and I think so many women listening, it was a moment where they were like, oh, I've never spoke about it from this before. There might be a problem. And I found that really, really fascinating, that I have been in the health sector for so many years. I'm so aware of how I feel, yet I had no idea of this complete disconnection of how I was feeling was due to my hormones. So for anyone who's listening to this and going, okay, so I might have PMS or I might have PMDD. As you said, there's no diagnostic test. What is the next stage for somebody who's going through this or maybe concerned about it? How would they be looking at it symptomatically to help diagnose whether it could be one or the other? Recent studies in the UK have shown a concerning trend. Nearly a third of Britons suffer with insomnia or severe sleep disturbances, with stress, screens, and sleep hygiene largely to blame. This isn't just about feeling groggy in the morning. The NHS has linked poor sleep with a high risk in chronic conditions such as heart disease, diabetes, obesity, and not to mention the impact on poor mental health. That's why I'm excited to share with you my experience with Natromat, a company that truly understands the science of sleep. Crafted in Devon with its organic, renewable materials, Natromat mattresses are a testament to what it means to sleep naturally. Unlike the common mattresses that trap heat and moisture, Natromat's use of organic wool and coconut fibre ensures your body remains at a comfortable temperature throughout the night, promoting a more deeper, restorative night's sleep. But what really sets Naturomat apart is their commitment to sustainability. As the UK's first B Corp certified bed and mattress company, they're not just talking about environmental responsibility, they're living it. From their solar-powered workshops to their groundbreaking Mattress for Life initiative, choosing Naturomat is a choice for a healthier planet. I personally visited Naturomat's showroom in Chiswick and I was amazed at their sleep zone. It's designed to give you a real sense of how their mattresses can transform your sleep. The calming ambience, the bespoke sleep aroma, and the privacy to truly relax and feel the difference. It's an experience that I would recommend to anyone who is serious about improving their sleep quality. For my UK listeners looking to transform their sleep and by extension their health, I encourage you to visit naturomat.co.uk. And don't forget, being a Live Well Be Well listener, you can get 10% off your first order using the code LIVEWELL. Invest in your sleep, your health, and your planet with Naturomat.
I think the most important thing is having knowledge and education about it, because it's something that, you're right, people have just had to put up with it, and it's like, that's just part of being a woman, that's just part of having periods, that's just your lot, really. And some of you might have heard I did a podcast with my oldest daughter Jess, who's has PMS, and she's now 21, but we recorded it when she was 20. And I say this in inverted commas, she only has symptoms for 3 or 4 days before her periods. And so you might think, it's only 3 days, it doesn't really matter. But 3 times 12, when there's 12 months in a year, is 36, which is more than any month contains of days. So that's a month of the year she's feeling symptoms. But actually, as she eloquently describes on the podcast with me, Mummy, it's not just those 3 days, because the rest of the days, I'm actually dreading those 3 days coming. And I actually feel a failure because I can't believe how bad I feel in those 3 days when I really want to give up my life and stop playing trombone and stop doing all the things I like. And I can't believe it's happened to me. And then every month I think, no, it's not really going to happen. I'll be able to sort myself out. And then you can't. And I think this is the thing. It's one thing, spilling a cup of tea and feeling a bit annoyed. And you're annoyed because you've, got to mop the floor, whatever. But this is like someone else controls your brain. And it is, of course, because your hormones control your brain. And if they're not there, you can't function. So you can't pull yourself together. You can't just, make another cup of tea and everything will be all right. And that's what's making it really difficult for the diagnosis. And then women are told, maybe you're anxious, maybe you can't cope with your job, maybe you're having a difficult time with your children. And women are tough. But actually, if we haven't got the tools, so having the information is really important. Downloading, Balance app, which is our free app, you can monitor your symptoms. You don't have to be menopausal to go on the app. And then look at your symptoms and just do a symptom checker at different times of the month and think, could this be related? And actually on the Balance app, we've got the sort of standard symptoms that you can do to put up a health report, the sort of standard menopause, like 21 questions. But we've added a lot more other questions that I think are a lot more relevant, actually. And looking at those, I think, is really important. And then reflecting, is there another reason why I'm having these symptoms? Or could it be related to my hormones in some way? And then once you've made that diagnosis, it's what do I want to do and what's the best thing for me? Because there's lots of different treatments. Of course, nothing in medicine is one unidirectional treatment. There's lots of different options, but also thinking about hormones, if they're changing, what can we do to just top them up? And this is where I think we should just call it hormone treatment, not a hormone replacement therapy, because replacement, we're not replacing. Therapy sounds like you need to be on a couch before you can even consider it. So just some hormone treatment to top up what's missing. And that's often all that's needed, actually. Sometimes I've given people just some hormones just for the 3 days where they've really struggled. And it's just lifted their hormones enough so they can carry on functioning. And that's really important. We need to look at nutrition. We need to look at exercise. Some types of vitamins can help people. But when I was a GP, I didn't know any of this for many years. And I was taught just give people antidepressants, but you could just give them for 2 out of 4 weeks, just give them for a short period of time. And I did, and people did sometimes feel better. but that's not treating the underlying cause, And so I think anything in medicine, we have to treat the underlying cause first. And if that doesn't help, obviously think about other treatments or treatment that might help. But I think as patients, we need to empower ourselves so we can guide that clinician and go into the appointment really well informed to say, look, I've monitored my symptoms for the last 3 months or so. There's definitely a pattern. There's nothing else that could be triggering it. I think it's related to my periods and my hormones. I would like to try X, Y, Z. And if that doesn't work, I could try ABC. And, have this informed decision-making consultation where, you can choose treatment as long as it's a sensible treatment. The first treatment might not work. It's like if you have a sore tooth, you might try paracetamol. If it doesn't work, you might try some ibuprofen, and that's fine in medicine. We don't always get everything right the first time, but we work with patients and do what's right for them.
So when we're looking at the mental health aspect, which is really important, before we get to the testing and the treatment, which I know everyone always wants to know because that's a really confusing landscape. You said something to me before which made me feel very calm coming to see you, because for me, I'd never even thought about what hormone treatment was, or that I would even be in a conversation about that. And you said hormones are the safest thing I've ever prescribed. Now, you mentioned there are a lot of people that might suffer with very low mood or depressive symptoms before their periods could get prescribed antidepressants, SSRIs. So how can people determine whether that route, SSRIs, is correct for them or the hormone route? Because I think that's a really confusing landscape, especially when it comes to like the mental health aspect. And how are hormones also working in our brain? Like, how is it affecting us that much in a mental health capacity?
Yeah, it's a great question. And the quick answer is it's impossible to know often. So our hormones, it's really interesting. So our hormones, estradiol, progesterone, testosterone are produced in our brain. So everyone focuses on our ovaries because we're always talking about periods and it happens just before our periods. But actually, and I've spoken to a lot of women who've had their ovaries removed, they've had their womb removed, and they still get the same symptoms. And because it's our brain that's controlling those symptoms. So one of the treatments for severe PMS and PMDD is to remove the ovaries. And it's very simplistic medicine. It might help with some people, so I'm not saying it shouldn't be done. But we have to remember that our brains produce our hormones as well, and they will fluctuate as well. So this sort of cycle that we have still goes on in our brain, whether we have our ovaries or not. And some women's brains are more sensitive than others. And what we don't know also is it the estrogen, is it the progesterone, is it the testosterone, is it the combination? And that's where you have to really fine-tune things. Now, antidepressants might have a role. Antidepressants can be very useful if someone's clinically depressed. And clinical depression is a diagnosis that we make by talking to people. PMS and PMD is a diagnosis we make by talking to people. And so often it's about having that clinical knowledge and experience. A lot of women with proper clinical depression have, you can fill out a questionnaire and you'll probably get the answers of being clinically depressed if you've got PMS and PMDD. But a lot of women I know aren't clinically depressed because they've got amazing insight and knowledge. And if I say to them, do you think you might be depressed? A lot of women say, no, I know it's related to my hormones. There is a difference. When people are often when people are clinically depressed, they feel very flat, very low. They actually don't care whether they're better or not. They often don't put on makeup. They don't have eye contact. They just are overwhelmed with sadness and apathy. Whereas often when people have low mood associated with hormonal changes, they can still have insight, this like, I want to get better, but I don't know how. Like I'm really struggling, but I know that this isn't me. And you can sort of, you have to have done quite a lot of psychiatry, clinical medicine to sort of notice it's very subtle. And we're actually funding a PhD student at the moment to try and work out what are the differences, but it is important. But the other thing is that with PMS and PMDD, one of the first things I'll say to people is, do you feel like this every day? And often people go, no, I have my period and then I feel fine. And then it happens again. So that is, my 13-year-old could tell you that's related to periods, And so But if it's affecting you in a way that it's really affecting the quality of your life, that's when you really need to talk to someone and get help. And sometimes we give both. If I was really worried about someone's mental health, I'm not going to be going, oh, it's all related to your hormones, don't worry. I might give antidepressants as well and then see, or I might start with hormones, add in antidepressants, and then see how that person responds. So because we're all different, but I don't anymore, because I used to, prescribe antidepressants first line because I don't think they're treating the underlying problem. And you know, there are problems with antidepressants. Of course, we know that they can be quite difficult to come off. Long term, they can increase risk of osteoporosis. You know, we also know that our natural hormones all work together in our brain. So they work as neurotransmitters, chemicals that send messages from one part of the brain to another. So if we've got better estrogen, progesterone, testosterone levels in our brain, it will boost our other hormones in our brain, so serotonin, dopamine and so forth, and melatonin to help us sleep. So isn't it better to naturally do it rather than synthetically do it? And that comes back to and I still stand by what I said when I first met you, is that hormones are the safest thing I've ever prescribed, and they're safer than the contraceptive hormones that I have prescribed for decades, because the hormones we prescribe usually for PMS, PMDD, perimenopause, menopause are just natural hormones. You know, they are biochemically exactly the same as the hormones we produce, which makes them very, very safe, really.
Mm-hmm. Well, we really distinguished that on the show last time, because I think I brought up around HRT, which is, you know, slightly different to what people will be experiencing if they have hormone therapy, which is maybe some natural progesterone or testosterone on the side a couple of times a month, or a couple of times before their period. But I think that is what blew my mind, that this conversation just doesn't happen unless you hit menopause or perimenopause. So we kind of spend, women, most of our lives, unless we're pregnant, not really understanding our hormone levels at all. And it is a really confusing landscape. When I've spoken about it since on my Instagram, and this is probably the first time I'm speaking publicly about it at all, after our conversation, I spoke to you and I said, you know, I really suffer with anxiety just before my period. I really suffer with heavy periods. I have burst cysts, but for my entire life, I was put on the progesterone only pill. And I felt great. But then I started to not feel great again, and I came off, and then I just didn't know where to turn. And you mentioned, you know, come and see me, maybe you might be hormone deficient. Had never entered my brain, ever. And I think that's the really interesting thing. We might think about going on a pill, like the conventional treatment to stop fertility, but we don't think about it in terms of how we feel. And then we might think about HRT when we reach menopause, but then everything in between, we just kind of struggle with. So when I came to you, it was very symptomatic. It was very like talking about how I feel. We did do a round of bloods just to check for any nutritional deficiencies, which I think was really, really helpful. And again, anyone listening to this thinking, wow, well, somebody in their 30s or somebody like Louise's daughter, 21 or 20, taking hormone treatment might feel a bit uncomfortable about it, might feel quite shocked about it. So I really want to lay the groundwork here and say, do we have a need to be frightened about this? Or is this totally safe for somebody in their 20s and their 30s to take with the symptoms that they're experiencing? Because I think that's probably the biggest fear for most people. And I can say personally, which is totally anecdotal, I've never felt better since taking this, and I had very low progesterone. And I only need it for a few days before my period, and it's really calmed me. My periods aren't heavy anymore. And I've never really spoken about myself like this on the show because it's not about me. But I do think it's really important to voice this for any women who are experiencing these symptoms and just think they just need to suffer because it's not fair.
Absolutely.
And so the stigma of me even taking that first pill, I have to say I was terrified. And then I felt great. And I was like, oh, I don't ever want to stop taking this. And so I think I really want to get into the stigma around taking this if you're not perimenopausal, because a lot of people will fight up that argument.
Yeah, and I think the thing is, I mean, there's lots to unpick there, but I think the thing is, when we give hormones, it's often called HRT, And if you Google HRT, it will say risk of breast cancer. And then everyone's like, oh my goodness, but I'm not menopausal. And oh my goodness. And that stemmed, we spoke about it in the last podcast, of evidence from 20 plus years ago using synthetic, so chemically altered hormones that do have risks, but this risk of breast cancer wasn't statistically significant anyway. But we don't prescribe that now. We just prescribe the same natural hormones. So people aren't scared taking the contraceptive pill, but it's synthetic. But they're suddenly scared when it's hormones because of this connotation, this hangover effect from this WHI study from years ago, thinking about HRT. But we're very simplistic when we prescribe hormones now, because we can prescribe the hormones separately. And you've just said you're taking some progesterone, and you might be that if progesterone didn't work for you, we would then consider estrogen, and you might need some estrogen added in. And actually, the beauty of starting when someone's got PMS and PMDD, we often can start very low dose, and we can just try, and then you sort of segue into having maybe a bit more as your own hormones decline. So in an ideal world, you will never experience perimenopause, and certainly never experience menopause, because you're just topping up what's missing, if you see what I mean. It's like if someone, I don't know, I'm just thinking how else to describe, if someone had raised blood pressure, for example, we treat it because we want to reduce future risk of a heart attack. Raised blood pressure doesn't usually cause problems. If it's very high blood pressure, it can cause headaches and people feeling quite tired, can sometimes affect vision. But we wouldn't leave someone for their blood pressure to be as high until it causes symptoms. That would be nonsensical. And it's a bit like this, because there's been so much misinformation about hormones, we have sort of ignored it, and women have then been, I see women in my clinic who are really struggling, they've given up their job, their partner's left them, they've got so many symptoms, their quality of life is dreadful. But actually, we shouldn't be waiting for that long. And the problem is also, I see women who are perimenopausal and menopausal, but they've got a history of PMS and PMDD. And then when they have the right dose and type of hormones, they say, wow, I wish I'd taken or started this 10, 20 years ago. So that's where this awareness is really important. And a lot of people with a history of PMS and PMDD then become pregnant, and they go, wow, this is incredible, because you've got good levels of hormones in your body. And that, for anyone listening, is a really important sort of telltale sign that actually, if you do feel so much better when you're pregnant, obviously there's lots of reasons why you can feel better when you're pregnant, but it is a soft sign that actually maybe you do respond adversely to hormones if you feel a lot worse when you don't have them at certain times of the cycle. But hormones like estrogen, progesterone, testosterone, when we prescribe them, they're very short acting. They only last the day that you use them, so they don't build up in the body. If they don't work, or someone has an adverse effect or a side effect, then you can stop it and they'll come out of your system. I spoke to someone today who's got lupus. She's had lots of problems. She's had some antibiotics. She's had some other medication for her lupus. She'd started HRT. She'd had these blisters and mouth ulcers, and she didn't know what was going on. And I don't know how much is related to her hormones. So she's just stopped everything. And then she's going to introduce very gradually one hormone at a time and see, because it probably wasn't related to her hormones. It's probably related to some of the antibiotics she had. But you never know in medicine, and it's always better to do things gradually and patients be in control. And I think that is the beauty, if someone has an implant, for example, once it's in, it will last for a few months or a few weeks, depending on the type. And then you can't take it out. If you have the depot Provera injection of progesterone, that's it, it's in for 12 weeks. This is very different. Even a tablet, it gets metabolized in different ways. We're very lucky that we can just give these hormones safely and try. And if it doesn't work, then you haven't lost anything, But if it improves, like you've had such an amazing response with very simple progesterone, and having the natural progesterone, Utrogestan in the UK, is a lot safer than having, the mini pill that you had when you were younger, because it's synthetic. So, we've got to stop this fear. And I think you often get scared of something when you don't understand. And that's what's happened. We haven't been given the information. And if you don't have the information, or you have wrong information about what hormones are, then the first thing you do is get scared. And that's where information and education is so important.
I think it's one of these things where people are listening, and I feel very lucky that my job, I managed to meet you and then come and see you for a consultation a few weeks later, as I've got to book in for an appointment. But for anyone who's listening to this and they couldn't come and see you, they just didn't have the access to you, such as the financial access, or they lived in a different country, or whatever that was, they don't have, and also you only have a limited amount of spots, can't see everyone who's got PMS or PMDD. What would the reaction be going to see a GP and asking for this? Like, I want to make that kind of statement because I'm thinking,
no, you're really,
it's really important.
And one of the reasons, we develop Balance app is so people can have free information. We update the information all the time so they can really feel empowered wherever they live and whoever they want to access. The problem is medical healthcare education hasn't caught up, and we have developed a Confidence in Menopause course which people can log on to. It's really designed for healthcare professionals, but it's not just menopause, so there's sections about perimenopause, but also PMS and PMDD. So really important that people have this knowledge as healthcare professionals. We've also produced some sort of treatment guidelines that healthcare professionals can contact us, and we can share that what we do in our clinic. And medicine is a science and an art, and the art is individualizing care and listening to patients. And over the last 8 years of dedicating my work just to hormones, I've learned so much. But there's also work that's been done in the past that has been ignored. So many women now who have PMS, PMDD have heard of someone called Dr. Catriona Dalton, who sadly now died, but she's written some great books about PMS and PMDD, and she writes very clearly about the effects of progesterone and how beneficial they were. And she, like we do sometimes, use progesterone vaginally because then you can get higher levels in the body and it's the pure progesterone. And it can be transformational for some women. But she wasn't believed and she had a really difficult time. The establishment went against her. And then no one sort of continued her work after she died. And we've sort of reactivated because she was years ahead of her time, like a lot of pioneers are, I suppose. And no one really, it's different now because when she was doing it in the 60s, 70s, 80s, we didn't have social media, we didn't have the internet. But in fact, even now, actually, one of my doctors who works with me emailed me today and said, Louise, this amazing lady I met had really severe postnatal depression. The psychiatrist wanted to give her ECD and antipsychotics, and she got hold of Catriona Dalton, and she was given Cyclogest, Pessaries, and she was amazing, and she felt so much better. And then her next pregnancy, she was given some Cyclogest, and she just wants to come and record a podcast with me, which is wonderful. But so people then found this doctor out, and people do, women have a way of connecting, as you know, but it's easier now. But what isn't easier is that sometimes healthcare professionals aren't catching up, or they're scared because they haven't been taught. But I think, the good doctors have some professional curiosity. If I have a patient asking me something, then I will always challenge myself and think, well, why are they asking that? Where have they got that information from? Could it make sense? And sometimes, people might come and be asking for some obscure tablet that they've seen on the Mail on Sunday health section that's been trialled on 3 mice or something. And of course, that wouldn't be rational to worry about that. But actually, if we're talking about natural hormones, which are biologically active, I've spent hours poring over basic physiology and texts and just looking at how our hormones work naturally in our body. Because if we know how something works when we're healthy and we don't have it, then it's easier to understand how important it is and how safe it is to replace it.
Mm-hmm. So do you think a GP now would be more considered to prescribe progesterone or estrogen?
I hope so. I mean, it is in the,
I want to give
the
listeners.
No, it is in some of the guidelines, and I'm hesitating because, I see a sort of skew population because in our clinic we see women from all socio-economic backgrounds, from all ethnicities, who come because the NHS has failed them. They don't come because they really want to see us, they come because they want help. So we don't see the people who are having a great experience, doing really well, everything else. So, you know, when I go to conferences in the UK and abroad, a lot of people say, gosh, Louise, your Confidence in the Menopause course has transformed the way I think. So thank you so much. So there is this effect that's happening. So it's always worth asking at your practice, is there someone who's got a specific interest in female hormones? Is there someone, nurse, doctor, pharmacist, who might be able to help me, to give me some individualised advice? Or is there someone in another practice? Maybe I have to change practice. Or is there a specialist in the hospital? So, you know, you're allowed as a patient to have second opinions. That's the other thing. I mean, I get quite nervous going to see my doctor because I think they're so busy, they're running late, they don't really need to see me, there's more sick people. And then if they say something, you sort of go, oh yes, okay, that's fine. But actually, you are allowed to have, and even as doctors, we don't all agree. It doesn't matter if we don't all agree, it's because there isn't really solid science. But we haven't got solid science that supports us. We don't have the evidence, because who's looked and done proper studies in women with PMS? No one.
Yeah, no, it's such an underrepresented group, which is really, really sad, because actually it can be the most debilitating, and it happens every single month.
Well, indeed.
And I've seen...
Yeah, go on, sorry.
I'd say I've just seen such a difference, and I think, how have I got to my mid-30s? And now I only feel a sense of relief, which is why I wanted to do this podcast, to help not just talk about the symptoms of PMS and PMDD, but like the actual treatment and the awareness that you can feel better, and you haven't got to have night sweats or have really heavy periods or have really bad migraines or really bad GI distress. All of these things that come with really bad PMS and PMDD. There is options, but I do think we all suffer. One of the things that I really wanted to mention, which is something that was mentioned to me in my consultation, and luckily I didn't have this at all, but it was mentioned that progesterone could make you feel worse. And I think it's probably important to raise that, not just saying that if you have these symptoms and you take progesterone, that you'll be fine. Yeah. I was very lucky that I did. But I think it's important to
No, it is, and thank you for mentioning it. So when we say progesterone, there are different types and different doses. So there's a lot of women who have PMS and PMDD who don't get on with synthetic progestogens. So this is like the progesterone-only pill. Even sometimes the Mirena coil they can be very sensitive to, because a small amount may get absorbed in the body, or other contraceptives. And then they think that's the same for every progesterone. Now, the progesterone that we prescribe in HRT, the Utrogestan, the capsule, is the natural, it's called micronized progesterone. So it's got the natural progesterone in it. It's been micronized, so made very small and suspended in oil so it gets absorbed properly. But it still gets digested and metabolized through the liver. So it does get broken down into other substances so it can get absorbed properly in the body. And some people find that they can't tolerate that. It can cause side effects. Sometimes people can get skin changes, bloating, but commonly low mood or sometimes anxiety. And then they say, well, I can't take progesterone. But like I've said before, we can give it vaginally. So it's insert in the vagina or actually in the rectum as well. It doesn't matter whether it's up the bottom, up the front. It then gets absorbed through the mucous membranes into the bloodstream as pure progesterone. So it doesn't need metabolizing. It doesn't get broken down at all. And so then often people find having it as the pure progesterone is very different. And then there are different doses as well. And so sometimes with the pessaries we can advise for them to be cut. And so people can start with a lower dose and then gradually increase. Now, progesterone is very anti-inflammatory and it's very calming on the brain, and it's very good for the brain. It's interesting, one of the first things that happens if we have a head injury or a stroke is that the brain produces progesterone to help repair it. And so the other thing is, though, because it helps repair the brain, it does have effects on the brain tissue and the nervous tissue and the way that even our sort of personality, memory, everything else can be affected. And there is not great evidence, but more clinical experience and knowledge that shows that when some women, not every woman, has an effect with progesterone, a side effect, it can actually sort of reactivate negative things that are going on anyway in the body. So if someone has had some trauma or a difficult situation, then it can catastrophize and make things worse as the body's healing themselves. It's a bit like if someone has some sort of cognitive behavioural therapy or other sort of psychotherapy, once it's all out on the table, you feel worse and then you feel better because you've shared it. And that can sometimes happen with progesterone. But if people know that it might be a short-term pain for longer-term gain, then it's fine. The problem is if you have something and it makes you feel worse, then you can stop it straight away and go, I'm not going there because that made me feel really sad and really low. And so knowing that actually I think is really interesting because like our brain is very plastic. And they talk about neuroplasticity, which means the sort of the brain can't really regenerate, can't get bigger. It's stuck in a skull, which is a fixed box, of course, but it can change the way it works and the pathways can change. And the way it's activated, the way the blood supply goes through, the way all our brain cells and nerve cells function together can change. But a lot of this doesn't change overnight. Some of the processes occur and alter quite quickly, but others you can have genomics or genetic effects that change, and that can take quite a few weeks or months. And so with hormones you have to be really patient as well, and most of us, myself included, are not blessed with patience. If we're unwell, we want to be better now, we don't want to wait. But if we have someone that can explain to us that you might feel worse before you feel better, or we can change the dose if it's not right for you, or we can start off very slowly and then increase, or there are different ways, then it's better. So, and that's where seeing someone who understands, it's not a one size fits all, it's not a, one treatment. And then sometimes people feel better giving testosterone or estrogen first and then adding in progesterone. Because the other thing I've seen quite a lot is, women who are still having their periods, they're still producing hormones. Of course they are. So if you then give progesterone at a sort of standard dose, they're having twice the amount of progesterone because they've got their own and they've got some endogenous progesterone, and for some women that might be too much. And so sometimes I will give estrogen if they need it as well, testosterone, and then monitor periods, and then that might, because they're producing progesterone with regular periods, they might need a little top up of progesterone, or they might not need any for a few months, and then when periods start changing we add in progesterone, because if you have too much of anything it can cause problems. So that's where it is a bit of a juggling act, and it is a bit of a fine art. But that's where working with patients is really important, because often once people start hormones, they know, are they having a bit too much? Is it one or the other? And it's also the balance of hormones. It's not just having one and increasing the dose on its own. It's looking at how the hormones work with each other, but also is how our external environment affects. So even this Katrina Dalton, who is way ahead of her years, talks about processed foods and talks about restricted time eating, and she talks about exercise and everything else. And our hormones work better when we've been exercising, when we're eating properly. She even talked about snacking through the day so our sugar levels don't drop too quickly. And it's really hard. A lot of us know before our periods we get sugar cravings. You feel this like insatiable hunger that is really hard to describe to people. But that's often the way our hormones work. But rather than just having, a chocolate bar or a packet of crisps, it's not going to help, because you'll get sugar cravings and you'll get your sugar levels will then go up and then plateau and go down, and then you'll feel worse. Whereas actually what you want to do is have something that's going to give you slow energy release. And that's better for your progesterone receptors as well, and your hormone receptors in your body. But if you know you're doing it not just to be healthy, you're doing it because it will help the way your hormones get absorbed, then easier to do as well. So that's where, but it's so much better if you've got all this knowledge before your hormones are all over the place, because otherwise it's quite a lot to take on board. No, of course not.
None of us have this knowledge. Why is this not a class at school for women? I'm just, like, when I first spoke to you, that was the one thing that I thought, why at 15 was I told to take naproxen, which for anyone who doesn't know, that's a huge anti-inflammatory, and then just go on to the contraceptive pill, even though I wasn't sexually active. So, you know, that was my treatment, and that had been my treatment for many years, and coming off it and having constant burst cysts, you know, the gynecologist was like, you better get back on the pill. So I felt this constant cycle of just, I don't know where to turn to. I don't even know who to speak to. I don't think anyone really knows how to treat me, so I'm a bit of a lost cause, so I'm just going to suffer. And I think so many women feel like that. And I think then when I started to have the conversation and went on progesterone, I can tell you something that really worried me, and I think this might be a worry for many people, which I actually haven't spoke to you about. But I think when you think, okay, well, I'm going to go on hormone therapy, okay, I'm going to take that, immediately my thought was, oh my gosh, am I going into my perimenopause? Or am I not going to be fertile? Or is there a problem with my ovaries? All of these thoughts come into your head, which obviously is like a huge fear for a woman. I can luckily say, like, I then went off and wanted to check that and it was fine. But I think that's a really big question that a lot of my community have come to me since, who are in their kind of early 30s and maybe have listened to that early menopause episode and gone, oh my gosh, am I menopausal? And I think that's a really big thing to talk about. Like, just because you get these symptoms, does that mean that you are at a higher risk of being infertile, or there's something wrong with your ovaries? Because you've just mentioned it's all in your brain.
It's really important. And, you know, I've already said 1 in 30 women will have an earlier menopause. But if you have an early menopause under the age of 40, it doesn't mean you're going to be infertile, which is really important, because one of the definitions of menopause is loss of fertility, but it's not actually for younger people. And we know that if women have their hormones back, then they're more likely to be fertile as well. And there's a lot of women I see who have been to IVF clinics in the past, might or might not have been successful in getting pregnant, but they've had a myriad of symptoms that have been blamed as, oh, you're anxious because you can't get pregnant, you're stressed, you're, you know, this, that and the other. But actually, when you unpick it, it's been related to their hormones. But actually, we know that having natural hormones is very safe, even if you got pregnant on them, because all you're doing is topping up the hormones. And increasingly, there's a lot of people who are progesterone deficient, and having progesterone can help improve the chances of becoming pregnant. And some of the treatments, I'm not a fertility expert, of course, but they often do give cyclogest, these pessaries, these progesterone pessaries I've mentioned before, as part of IVF treatment for some people. And actually, in the first 3 months of a pregnancy, you want to have a lot of progesterone because it helps support the developing placenta and the fetus, the developing baby. And then after about 3 months, the placenta then takes over and produces all the hormone. And so actually, it can be very reassuring to know that not only are you not going to worsen your fertility, but you might improve it. Some people worry about taking testosterone when they're undergoing fertility treatment or want to become pregnant and conceive or try and conceive naturally. But actually, with testosterone, we're just topping up what's missing. So you're not going to suddenly turn into a man, and it's not going to affect your fetus. So it's important that people are reassured by that. There's all sorts of tests, as I'm sure you know, for fertility. Some of them are just a money-making thing.
You have to be really careful.
So you have to be really careful for that. And a lot of specialists in IVF are not trained in hormones. So it's really difficult. But actually, you know, the doses of hormones that people have for IVF treatment or have because they're pregnant, the levels that they have in their body are so much higher than what we're talking about with a tiny, tiny bit for PMS, PMDD, perimenopause, or even menopause.
Mm-hmm. I think it's such a big conversation now because so many people are worried about fertility or freezing their eggs or worried about an early menopause or perimenopause, because amazingly this is now all coming much more into the conversation. And one of our listeners wrote in, which I thought was a really good question. She said, if you see changes in your periods, at what point do you go to the doctor? And at what point is it really bad? And I thought that was probably quite a good question to put into this mix while we're talking about it. What would you say to anyone who is maybe seeing a change in their period?
I think the sooner the better.
Point?
It really is. I don't think we should normalise heavy periods. I get shocked with stories that people tell me, and they say, yeah, my periods are a bit heavy. Yeah, I just have to change my tampon, every half an hour, and I'm always flooding, and I'm at bed always, and I'm just like, what? Have you ever seen a doctor? And often
this is our conversation.
Yeah, and often they say, well, I have seen a doctor, but they say, oh, well, heavy periods are really common. But there's two issues here. One is, I don't feel anyone should be having heavy periods because there is treatments that will help heavy periods. But the second thing is heavy periods could be a sign of something. So it could be related to endometriosis, for example. It could be related to PCOS, polycystic ovarian syndrome. It could be related to a hormonal imbalance. You've already said your periods are lighter because you're having progesterone. So we should be on a bit of a hyper alert and seeing. I mean, it's interesting journey, isn't it? My 13-year-old started her periods a year or so ago, and a few days ago one of my other daughters said, oh, Mummy, Lucy was just crying in the shower and it's so awful. And my mum was saying, well, you need to go and talk to her. And I spoke to her a couple of days later to say, what happened in the shower? She goes, oh, Mummy, I just had my period the next day. She said it was fine. But she knew that she would feel like that. And I'm not going to rush and give her any hormones. Of course not. She's young. She's fine. She's got insight. I'm keeping an eye on things. But knowledge is power, because otherwise I would have really worried that my 13-year-old was crying in the shower. She would have worried, is there something going on, or has there someone been mean at school? Or she might have catastrophized the situation. So knowing that the hormones can make you feel a certain way, that's where knowledge is important. But as she gets older, if her periods are very heavy, then there are options. And, just to mention really for older children and adults, so not my 13-year-old, but, there is the Mirena coil for older people, which we mentioned before, which is synthetic. But for many people, they tolerate it very well. And it usually stops periods and is very good for contraception. But there's the Jades and Kylena coils, which are smaller and they last for less time, but they can be really useful, especially for people that haven't had children, because they really good contraception. They usually just work locally and they stop periods happening. They don't really interfere usually with the other hormones, but you can still have hormones additional, so you could still take progesterone and estrogen and testosterone if you needed, but then you're not having the heavy periods. So that's an option. And then sometimes obviously hormone replacement therapy or hormone treatment isn't a contraception because it's not licensed as such. So there are the contraceptive pills which can help, but some of them are more synthetic than others, and some of them can cause side effects, as you know. There is one called Zoli, which is more of a natural contraceptive. It's estrogen and a progestogen. It's more expensive than some of the others, so some people really struggle to get it from their doctors. It's not that expensive, and it's really frustrating because you want a pill that's going to be as natural as possible if you can. But knowing that there are options, I think, is really important. And certainly as a doctor, whenever I give a treatment, I usually end the consultation by saying, do you know what, if this doesn't work, we can try this. Or if this has a side effect, there's something else. Because as a patient, you want to know you're not last chance saloon. You're not, this is the end of my treatment journey. Because there are always options. And I said before about removing ovaries, which is quite an extreme treatment, but there are blockers that people have. So you might have heard of something like Zoladex, where it's an injection that blocks hormones, and lots of people, mainly gynecologists, give it and say it's great because it will stop your hormones fluctuating, which it does, but it basically gives you a chemical menopause. So then we can give back hormones. So we can give back estrogen, progesterone, testosterone at natural, low, steady levels, which can make a difference. And sometimes, yeah, absolutely. And so some people with endometriosis are now given Zoladex to stop the estrogen sort of stimulating the endometriosis tissue and calm down, but often people feel dreadful and they might still have endometriosis.
That's a big operation.
Yeah, absolutely.
That is a really big operation.
Yeah, so then we can often give maybe just some testosterone or progesterone. And so it's working with symptoms, working with the patient, being really individual is really important.
You mentioned something there, and I really want to make sure I touch upon it because we haven't yet, which is PCOS, polycystic ovary syndrome. And they have any women that are diagnosed with that normally have very high levels of testosterone, which is one of the things that you've mentioned of the 3 hormones. Is there any challenges for someone who's listening to this with PCOS when they're considering hormone therapy or any of the stuff that we've discussed?
Polycystic ovary syndrome is one of those conditions that I think is so poorly understood. So, there are certain diagnostic criteria, like you have to have cysts on your ovary, you have to have something in your blood test, you have facial hair, whatever. But lots of people don't actually quite fulfill it. But it's also, I just think, it's another imbalance of hormones. So people can have high testosterone relative to the other hormones, but actually this is where it's important, relative to other hormones. Now, estrogen might be low, progesterone probably is low, and we can't always do blood tests because they fluctuate. And the levels of hormones in my blood are not going to be the levels of hormone in my brain or my other tissues either. And they can vary throughout the day. So I don't want a blood test taken 24 times a day to see every hour what my hormones are doing. I mean, that would be painful and unnecessary, but it's still not going to tell me what's going on in my brain. But the thing about polycystic ovarian syndrome is that people always say, it's about the cysts on your ovary. It might be associated with fertility changes, but it's a metabolic problem. And there was another study that came out today highlighting the increased incidence of heart disease, osteoporosis, diabetes in women with PCOS. Oh, what a surprise. These are the same diseases, increase in menopause. And we know it will be related to changing hormone levels. And in PCOS, it's probably more estrogen and progesterone. So I think it would be great, wouldn't it, to do a study giving women who have PCOS, progesterone and or estrogen and seeing their response and look at their metabolic processes as well. Really, really important. And so, a lot of people then with PCOS struggle to lose weight. It's all very well saying, just eat better, but even when they do, their metabolism is quite different because of their hormonal changes. And a lot of gynecologists don't really understand the metabolic changes. A lot of endocrinologists don't really understand PCOS. So these women often get just in the middle and they try and work it out themselves. It can be very difficult actually. So, but like I said before, there's often, not always, an overlap between PCOS, endometriosis, PMS, PMDD, maybe reduced fertility as well, and even Ehlers-Danlos, which is hypermobility syndrome, can be associated with all of these things as well. I think anything where people have been labelled as, it's in your head or it's a personality disorder, then it's often related to hormones actually.
Hormones.
Yeah.
Isn't that so sad that that's how it's just placed on women? Yeah. I'm just thinking about all of these kind of stigmatized comments that come out, and it's all with women with hormones, but it's the least supported area, and also it's probably the most hardest one to navigate because it can also feel like a bit of a cowboy market out there and very unethical when it comes to this as well. For some people, finding stuff online and trying to test their hormones and feeling really lost, or somebody not listening to them. And I think with everything that we spoke about, how there isn't this gold standard test, how it is about symptoms, and having a conversation with somebody like you, your GP, and tracking your symptoms is really important. So downloading the Balance app, having like a period tracker app that can be really good, so you can kind of like see when are your symptoms mostly coming up. And I think that really, really helped me as well when I was coming to speak to you. But I think something that we haven't touched upon, and this is, again, because it's stigmatized, is how do you talk to this about your partner or the relationships around you? Because I think that conversation with yourself is difficult to even get treatment, yet even recognizing that with people around you can be really difficult. So do you have any advice on people who are listening to this that maybe they're feeling within themselves a bit of stigma, a bit of shame, and oh gosh, I feel like that, which they shouldn't at all, but of course it's natural, because I know I did. How can we then go about having these conversations with kind of the relationships that are around us?
it's so important, and it's not just your partner, it's your family, it's your friends, it's your work colleagues. Really important. And in my book, The Definitive Guide to the Perimenopause and Menopause, I do talk about PMS and PMDD, and there is a section about talking to family and friends in there, because it's so important, because otherwise you're just seen as this hormonal nightmare to be with. And it's really quite isolating when you're having hormonal changes. You feel quite vulnerable, you feel quite neglected, you can't always express what you're saying because your brain isn't working properly, and you want someone to understand, and you want someone to recognise, actually, because sometimes it might be your partner or your friend or your work colleague who says, do you know what, Louise, certain days of the month you're just not quite yourself. Do you think anything can be related to your hormones? Have you read this book? Have you downloaded Balance? Have you read this article? Listened to this podcast? Maybe I could come with you and talk to the doctor about options. Because when you're with yourself 24/7, you don't always notice, or you blame it on something else. You just think, oh, it's because I'm tired, or because the sun isn't shining, or because whatever. So I think, actually, even if you're listening to this and you don't have symptoms and you're female, you are going to have some hormonal changes at some stage. Say to people, can you just have a read of this, so that if I do change, you know what's going on. And I think we need others to help us, actually, with this.
And you had your own personal story with that, didn't you, as well? I mean, you really know it from a medical point of view, but from a personal point of view as well.
Yeah, I mean, it's awful, actually. I mean, when I was perimenopausal, and I don't really think I had much period. I would have had a bit, day before, but my periods were not a big event. They just happened. But I had a few months where I felt like my brain had been taken over by this demon, horrid thing that was just allowing me to shout, to be irritable. I mean, the brain fog and the memory problems were really awful and scary, but it's this sort of anger that a lot of people describe as well, which is really difficult, because normally if you're cross, you can count to 10 and suppress it, or just walk out of the room and you're okay. But it's like someone gives you permission to be really horrible, and that's a really awful place to be. And I'm fine with, we've got a very stable family, there's a lot of love in our home, but there's lots of homes there isn't, and it doesn't take much for it to be really on the edge. And that's what really worries and scares me with this, because people, if you don't understand, and I did a podcast with someone about PMDD, really powerful story with a lady, and her husband's still with her, but and she doesn't know how either. I mean, what her children were exposed to was quite extreme and awful, but she knew it wasn't herself. And this is a big key. If there are times in the month that or your partner knows, this isn't the real you, then I just think, ask the question, could it be related to your hormones in any way? Exclude your hormones first, and then work out what else is going on.
If there's one takeaway that you want the listeners to leave this episode with, what would that be surrounding their hormones?
Just knowledge, and knowing how they can get everywhere, to every cell in our body, every organ in our body. The power of hormones is immense, and it's been neglected for so long.
I mean, I completely agree. I can't believe, and I say it because I feel you went through the same thing that I was in. I've been in the wellness field, or well-being field, for over 10 years now, in clinic, and working with patients, and running a mental health organization, and doing the show. And still, I was unaware. And so that's why I think this conversation is so, so important. Because if I'm in the epicenter of it and I don't even recognize it, I then think, how is anyone else going to recognize it? Because I talk about this all the time. And it can be really hard, I think. And that's why I want anyone listening to this just to take a moment and pause and think, have I related to anything that's come up in today's episode? Because so many times we might listen to it and glance over it and think, oh, I'm not that bad. No, I don't get angry. Oh, I only cry once a month, it's fine. But they never are really honest with themselves. And I think there's no shame or stigma of knowing that actually you do feel like this for maybe a good week or more. You are a nightmare to be around, all of those things. But that also takes a lot of strength to get to that place. So I think if anyone does relate to this, there's power in knowledge, knowing that you don't have to feel in that way, which is great. So I always leave, Louise, and I know I've asked you this before, and I'm wondering if you remember, and you might do. But it's what I leave with all my guests, which is, what does live well, be well mean to you?
Yeah, I can't remember what I said before, but I think
I know what you've said. I'll tell you after.
You can tell me after, but I think live well, be well is actually, and I hesitate here because it's sounding a bit cheesy, really, but being surrounded by people you love, and also having that internal love, which I think is the hardest thing to do. You don't have to love yourself, but you have to respect yourself, because then you're going to radiate more love and more positivity to others. And the more I lean on like good people, the happier I feel. And I think if you're not surrounded by love, then anything else just falls out. And yes, we can talk about nutrition and exercise and everything else, but I think, love and respect for people is really powerful.
Yeah, love for other people and love for yourself. Self-compassion. I mean, it's my word that I use a lot, but yeah, love for yourself. It's really important. Do you know what you said last time?
No, go on, tell me.
It says it takes a while to live well, be well, but when it does, it doesn't need to be 100% of the time.
Yeah, that's true as well.
And I liked that.
Mm.
Yeah, I liked that. I think that they're very similar. Don't have to be perfect all the time, but you do have to have respect for yourself, which is important.
Absolutely.
Louise, I know everyone, you've mentioned a couple of things here, Balance app, your book. Could you please give all of the information, because I know that this podcast is not going to be enough information, much as we tried to get everything in. We didn't even touch upon diet, but we didn't have time. But can you give all the resources where people can go and find you, please?
Yeah, the easiest thing actually is just to go to drlouisenewson.co.uk, and then you can springboard into anything from that website and see what I'm up to, what I'm doing. And follow me on Instagram, menopause_doctor. That's where I spend a lot of my time, just explaining where I am, what I'm doing, how I'm helping. And, it's a joint up effort. I don't work on my own. I work with an amazing team. But, there's lots of women who are working together to really amplify messages, which is great.
Yeah, women supporting women, it's so important. And honestly, if a man's got to the end of this episode,
Well done.
Huge accolade for you. Well done. And I'd say to women, if anyone's worried, when we were talking about getting support, send them this podcast. Just send it and let them listen to it and let me realise that, it's not just you that goes through this. So thank you so much for coming on.
Thank you.
Thank you so much for just changing my life. And I've never said that before, but it means a lot. And I really hope that this touches many women who are listening to this as well.